DB05 came, on, of course, the heels of the long-established KATHERINE trial. And in KATHERINE, the use of T-DM1 in patients who had residual disease resulted in, cutting that risk in half. That hazard ratio was almost cut in half. And then adding about, 11, 13%, depending on the point of analysis. And then, as you pointed out, people who have had any amount of residual disease benefited from T-DM1 over trastuzumab. And then comes DB05 on the heels of that, randomizing the patients who had received standard of care treatment. These were not DB11 treated patients. And then randomize them into receiving essentially T-DM1 as a standard of care versus T-DXd, both for 14 cycles every 3 weeks. And very interestingly and reassuringly, and for the patients, the risk was almost cut in half again. And then adding another another about 9 or 10% to the DFS. And of course, that was a really important outcome for the patients, improving their DFS. That of course comes with 14 cycles of T-DXd over T-DM1. And of course, with the same rate of ILD/pneumonitis that we've seen on the metastatic studies that kind of used, T-DXd longer, So that's why, the DB11 was a little bit of shorter duration, so lower. But the same incidence of ILD that we've seen in other trials was seen also in DB05. And there were 2 treatment-related deaths on the trial as well, again, mentioning them. And so really it was a massive new step in improving outcomes for patients with residual disease, and another testament for why neoadjuvant treatment is important, particularly for high-risk HER2-positive breast cancer. This has led to, as you pointed out, Joyce, the NCCN was ahead of everyone and endorsed it almost immediately. And then the FDA most recently, as of maybe a couple of weeks ago, approved T-DXd for the adjuvant indication of residual disease of any amount, which was a broader indication than many have expected.
Yay.
That presents a very potent new option for our patients.
That really was a game changer, I thought, this broad label for any residual disease. It'd be interesting to see how we apply it. We were comfortable with the T-DM1 if they had the 1 millimeter, because we had really extreme data there. We had good data from KATHERINE showing that they benefited too. But that is really, really good, because it allows us to really think through for individual patients, because the initial eligibility, you had to be either inoperable, so like a T4 disease, or you had to have N2, N3 disease, to be eligible for DB05. So it was the highest of the highest risk, and so that was going to be very limiting in terms of who we could apply it to. But now it's wide open, so it really allows us to think who we're going to give preoperative and who we're going to give adjuvant to. So, Anthony, at MD Anderson and in your own practice, again, you're on the front line with these patients and telling them what the residual disease and what surgical pathology outcome is. Have you guys started to talk about, you start to use the DB05, and it's been hard for patients to, more hair loss, as opposed to the T-DM1 without the hair loss. But how do you, because I've learned that unless the surgeons lay the groundwork and tell people in advance, it's not happening, basically, So, So what's been your approach?
I mean, I think the data was so striking. It was like 53%, something like that, risk reduction. It's a huge risk reduction.
It's cut the risk in half.
It's such a big difference that I think immediately we were, the great news is that for patients who do come back and they have some residual disease after treatment, we could say we now have great options that will cut your risk significantly. We're going to send you back to the medical oncologist to discuss that, and usually we have a brief mention of it. And I think that's actually been very well received. I feel like because I think in the past, you're right, it's often difficult, especially patients with a large RCB, RCB2/3, and they're saying, what am I going to do? At least now we still have really, we have so many good options. We see a lot of locally advanced inflammatory breast cancer patients. And so even in this group of patients, we've seen, we now have good options, and we're seeing much improved outcomes. So I feel like it's a very positive ray of hope, whereas before it was always a little bit, I mean, TDM1 was the first step, but this seems like another
leap.
step up.